This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or redistribution of the videos or materials may only be undertaken with the prior written consent of the AARC. Copyright 2023, all rights reserved. Thank you all for joining us today. My name is Emilee Lamorena, and I'm the Director of Respiratory, Pulmonary, and Asthma Program in CHOC Children's in Orange, California. I also serve on the Board of Directors of the AARC as the Chair of the Neonatal Pediatric Section. Welcome to today's program, Clinical Management of Bronchiolitis, from Mild to Critical. Upon completion for this AARC program, the participants will be able to define what bronchiolitis is and what it isn't, provide guidance on the clinical presentation and assessment of bronchiolitis, and discuss interventions and clinical management of bronchiolitis from mild presentations to critical bronchiolitis in the PICU. I am so honored to introduce today's speakers, Annie Geistkemper and Dr. Stephen Shein. Annie Geistkemper is a neonatal pediatric section manager of respiratory care services and an instructor in the Department of Cardiopulmonary Sciences in the College of Health Sciences at Rush University. She graduated with a Master of Science in Respiratory Care from Rush University in 2012. Ms. Geistkemper is involved professionally as an AARC Education Section Preceptor, AARC Exam Prep Faculty Member, ISRC President-elect, and ISRC Program Committee member. She has also contributed to peer-reviewed publications and presented at conferences. She was most recently awarded the 2021 AARC Neonatal Pediatric Specialty Practitioner of the Year Award and the 2022 ISRC President's Award. Dr. Shein is an FCCM trained in pediatric critical care at the Children's Hospital of Pittsburgh. He is now the Chief of Pediatric Critical Care Medicine at Rainbow Babies and Children's Hospital, where he is also the Linsalata Chair in Pediatric Critical Care and Emergency Medicine and the co-director of the PICU Clinical, Basic, and Translational Research Program. His research focuses on acute respiratory failure, particularly bronchiolitis and asthma. He is a co-editor of the Pediatric Acute Respiratory Distress Syndrome, a clinical guide textbook, a member of the Second Pediatric Acute Lung Injury Consensus Conference, and the former chair of the Society of Critical Care Medicine Clinical Research and Epidemiology Committee. Neither the presenters nor I have any relationships to disclose. Brand names and/or medications may be mentioned only as examples of technology. Any use of brand names is in no way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability. I'd now like to welcome Annie.
Thank you so much, Emilee. Welcome, everybody. We are very excited for today's presentation. We are going to be talking about bronchiolitis. So our objectives for today are to define what bronchiolitis is and what it isn't, provide some guidance just on the clinical presentation that you're seeing at your hospitals, and then kind of describe the current management from mild to critical. So what are we dealing with here? Bronchiolitis is one of the most common infectious diseases of the small airways. It accounts for 100,000 inpatient admissions per year. And around 18% for children are under the age of 1. 13% of those are PICU admissions. And I don't know about you guys, but I feel like we felt that this past viral season, which came unseasonably early. So we're also talking about bronchiolitis being this RNA virus. So it's supposed to be seasonal. It's supposed to appear in those winter months and those different environmental conditions. And then we know that it's an obstructive airway disease of the lower respiratory tract, so we know anybody kind of presenting with that big picture there is going to be coming and being diagnosed with bronchiolitis. So what does the clinical presentation look like? We know that we just kind of referred to the etiology. If we talk about bronchiolitis, we're talking about, different different respiratory viruses that come about, how it's transmitted. We talked about it being seasonal, but there are certain patients, as with most different infections and diseases, that are going to be at higher risk. So some of those risk factors are listed here for you. And of note, premature infants are usually always on that list of those that are at higher risk. It definitely feels like right now cases are starting to decline in certain areas, but these patients who are presenting with those signs and symptoms that we spoke about and some that we'll talk about going forward are still going to be at high risk, not necessarily dependent on season. So the epidemiology is for patients less than 2 years of age. So the incidence that's been reported about bronchiolitis said that 11 to 15% of infants are typically under a year, like I previously mentioned, but it really is for those less than the age of 2. And the data shows that there are 5 hospitalizations for every 1,000 children who are under the age of 2. In terms of pathophysiology, the virus infects the epithelial cells in the airways, and it induces an inflammatory reaction that then leads to this ciliary dysfunction and cell death. The accumulated debris from that inflammatory reaction causes edema in the airways and maybe even narrowing of those airways due to the release of the cytokines, and eventually leads to symptoms and lowered lung compliance. So the patient then tries to overcome that decreased lung compliance by breathing harder and breathing faster. So if you were to put out there one of these jam boards, I think there's a couple other names for this kind of tool, and say, okay, what are the most common things you're going to see? How is your patient going to present if they were to have bronchiolitis? This is kind of what this would look like. Almost every single patient has some sort of respiratory distress. You might also see fever presenting depending on what day of the infection they are on. And then those at the top there are not necessarily less common, but less noticed right away are those wheezes, retractions, dehydration, crackles, and tachypnea. Of note, if you are dealing with a neonate or a brand new newborn infant, sometimes you may see those patients present with apnea or cyanosis, which would be an immediate clinical emergency. Okay, so back to that clinical presentation and the assessment. So we know that the peak of bronchiolitis is typically day 3 to 5 from the onset of symptoms, not from the day of diagnosis. So as a clinician, it's important to really gain that good history with your patient and hopefully their caregivers that are there with you to really figure out what day of onset you are on. So if you picture the environment in the ED, that patient is most likely going to get some sort of nasal swab to run the panel to see kind of what we're dealing with. But prior to admission, chest x-rays and labs are not actually needed. If the patient is presenting with severe symptoms, then we use those assessment tools that we'll kind of talk about a little bit further and figure out what is appropriate for that patient or figure out what we need to do for a differential diagnosis. So if you look here on the left, these are going to be a little bit more of our mild symptoms. And I don't know about you, but sometimes, as an adult, I still have some of those symptoms when I get sick. So in our kiddos, we know that those are very, very common symptoms. I'm sure if any of you are parents, your kids just went back to school after Christmas break and everybody's got a runny nose again. So very relatable when you see these kinds of kids come through the ED. Hopefully, we're being able to capture some of those kids and preventing them from even having to come to the ED just because of the plethora of information that's been put out lately about this season of bronchiolitis. So hopefully we can manage this with some over-the-counter medications and saline and stuff that we'll get into. On the right side here, these are the kids that we're talking about that are in our emergency rooms or our immediate care centers. They've had a high fever. Maybe it's new, maybe it's a couple days. they're retracting. You can see them clearly working. They're not taking good PO. They're very dehydrated. They've got audible wheezes, or their breath sounds just aren't ideal. They're a little bit diminished, and our saturations aren't good. So these are the kids that we're seeing in the ED that we are trying to act immediately upon and try to get them captured so that we can help their work of breathing and kind of help them settle out. So how should we manage this? So despite 20 years of messaging suggesting that less treatment is better and that we should be more supportive rather than interventional, the de-implementation of interventional care still hasn't quite occurred. It has gotten significantly better, but we're not quite there yet. So the 3 S's are something that I kind of made up as just a mnemonic for me to remember as I respond to these kids in the ED, and just as my mental check boxes of, are we really optimizing their care? So let's break down those 3 S's. So we have their saturations. What are they satting? Are they on room air? Do we have them on oxygen already, dependent on how they're presenting with us? Suctioning is an important and almost underutilized tool that we can use to help them overcome their work of breathing. And then how are we going to support them? It can be from something very mild to something a little bit more critical. So if we dig into saturation, so this can be achieved by providing oxygen if they are below our saturation limits. So we would want to administer oxygen to achieve a saturation of an SpO2 greater than 90%. And the data shows that if infants with bronchiolitis are satting greater than 91%, there's no evidence to support the usage of low-flow oxygen therapy. It actually prolonged length of stay in those particular studies. And so there's been high-quality evidence that showed a lower oximetry threshold of 90%, where oxygen is then started, is safe in the short term and could reduce length of hospital stay. So we're really trying to be judicious with placing these kids on oxygen, and that's a big culture shift, right? We don't like to look at bad numbers. We don't, but because we want to fix it. We're fixers. So the data right now is showing, though, that we probably need to be a little bit more gracious with their saturations, and not necessarily apply oxygen unless they're below that 90%. All right, let's talk about suction. As RTs especially, we love this topic. So data came from the Lancet journal, where we know that these infants who are presenting with bronchiolitis are obligate nose breathers. So it's very attractive to use suctioning and potentially even maybe nasal saline to clear their nares. But there's no randomized controlled trial evidence. The current guidelines support superficial suctioning, though, versus deep suctioning. So the difference there really is that deep suctioning isn't supported by enough data to say, yes, we need to be deep suctioning every kid who we think is coming in with suspected bronchiolitis. But superficial suctioning is. And what does that mean? So depending on the device that you're using, I know there's plenty on the market there. We're just staying in their nares. We're not going anywhere past their nares. With suctioning comes that thought of CPT as well. And the evidence also does not support the routine use of CPT in these patients. And it's really only reserved for those who have those relevant comorbidities with difficulty of clearing secretions. So clearly, though, there are still some gaps, and we need some more randomized controlled trials in order to kind of better navigate this. All right, and let's get into support. So hydration, hydration, hydration. And that is one of the hardest things, and probably in this is my perspective, not data related, where these kids end up coming into the ED because they're just not drinking or anything at home, and they're getting weaker. And so, a parent or caregiver's threshold is, appropriate to then bring them in. So we on the clinical side then would be starting IVs and hopefully giving some fluids so that we can get them hydrated again. We want to make sure we monitor them for any increased respiratory distress and support that appropriately. So those 3 ways there are listed. The inhaled therapies, non-invasive, and high flow are going to be 3 options that we have to be able to support their respiratory distress. And if we talk about the inhaled therapies, a very controversial topic when it comes to bronchiolitis. So the American Academy of Pediatrics recommends against the routine use of bronchodilators. So they performed some data in regards to hypertonic saline, and as well as the Lancet Journal, who reported that a large randomized controlled trial did not show any significant use of hypertonic saline. Another study ended up showing that the primary outcome was length of stay, and the difference in length of stay that they were studying had no significant difference. And then there was a third study as well that was a prospective, double-blinded, randomized controlled trial of infants with moderate to severe acute bronchiolitis, and showed that hypertonic saline usage did not show any clinical significance. So it's probably still happening out there, so there's clearly still some more gaps that need to be filled, and we need a large multi-center trial to really show if there's use for hypertonic in bronchiolitis management. What about bronchodilators? Well, according to the Lancet, they reported that the use of bronchodilators didn't necessarily reduce hospital admissions, and another study found that early bronchodilator use in the hospital didn't reduce any outcomes, meaning that just because they came and they presented with what appeared to be bronchiolitis, we shouldn't just give them albuterol necessarily. So there wasn't enough data to support that pathway. Again, when we talk about hypertonic and albuterol, we really need any of you passionate researchers out there to help us to really gather some more data in some multi-center trials so that we can hopefully get to a point where we have something to support our clinicians at the bedside to give us a better pathway. All right, high flow nasal cannula, the high flow topic. So while there's not a concrete definition for a high flow, it has been defined as a flow of 2 to 3 liters per kilo up to a rate of about 40 to 60 liters per minute, depending on age and size. But there is no standard protocol out there right now for initiation, escalation, or weaning of high flow in the PICU. That doesn't mean that your facility doesn't have one. There's just not a standardized approach necessarily. So when we look at this, when we learn about things, do we ever really just learn them without having some sort of assignment to coincide with it? We really have such an opportunity here to educate our colleagues about the usage of high flow nasal cannula. So depending on the product that you use, we as RTs can better communicate the acuity of our patient. So if you picture the device that you use at your facility, and the patient is on that, I think that we have an opportunity, especially as respiratory therapists, to kind of perfect our language so that we're really defining the acuity of these patients appropriately. So for us, the version that we use, it could also serve not only as high flow nasal cannula, but it also serves as high humidity nasal cannula, which is not as acute as just a high humidity nasal cannula. So for us, we have to learn to speak a better language so that we're really broadcasting the acuity and the severity of those patients as they stay with us. So the data out there is showing that a few studies, mostly done across New Zealand, France, and Australia, they put their data together, and it showed that high flow shouldn't be used as a primary modality in bronchiolitis with hypoxemia, but it should really be reserved for escalation of therapy if that low flow fails. So remember before when we were talking about low flow oxygen, we're going to initiate that regular nasal cannula if our saturations were below that 90%. So if that's the case and we're not able to still capture them with low flow nasal cannula, then would be the time to escalate to high flow and really capture their work of breathing and hopefully meet their saturation goals. So we clearly have a gap here with some high flow, and we're going to talk about some studies really quick, but there's a precise definition of treatment failure for low flow oxygen, and we need a better defined population where high flow nasal cannula is going to be most appropriate. All right, so one of the first studies I wanted to talk about was from Willer et al., where they talked about a weight-based high flow nasal cannula protocol that they developed. So while everyone has been saying that we're using too much high flow, but de-implementation hasn't really happened either, Willer decided to look and see if a weight-based protocol would have an impact on these pediatric ICU patients. So the outcome measure that they looked at here was proportion of patients that were treated in the ICU. So any patients with complex medical conditions were excluded, though. So they looked at patients that were less than the age of 2, who had a discharge diagnosis of bronchiolitis or viral pneumonia, and those were the date ranges for this study. And so what this team did is they defined their target flow rate. So they chose a standard flow of 2 liters per kilo per minute with a setting max flow rate of 20 liters for those that were greater than 10 kilos. And this hospital was using an age-based flow protocol. The primary outcome that, like I said, they were looking at ICU utilization, and some secondary outcomes there are listed. So there was an immediate absolute change in the ICU utilization of about a -4%, which had a 95% confidence interval. And for the secondary outcomes, there was an immediate reduction in the median cost of bronchiolitis encounters, which was about $661, and the number of patients who received NIV. Most studies prior to this showed that there was no improvement or even an increase in ICU utilization after implementing protocols, but it's key to know that those studies used age-based and modest flow rate, where this study used a strict 2 liters per kilo per minute. So if we try to understand why ICU utilization decreased, Wilner explains that it could be that the higher flow rates captured those patients sooner and decreased their work of breathing, therefore may have prevented an ICU transfer. There also may have been a perception that because they were allowing a higher flow rate at baseline, that the ICU was unnecessary, right? So if your kid is in the ED and you come down there to assess them and they're on 3 liters and their work of breathing is extremely high, but when you look at it, they should really be on 10 liters based on their 2 liter per kilo per minute. Well, all of a sudden you put them on 10 liters and now they're captured. When if you would have just started at 10 liters, you wouldn't have maybe necessarily thought they were as bad because you're starting at that much higher level to capture them. Another study was from Peterson in 2021, and this group had an RT-driven high-flow nasal cannula management protocol in the PICU, and I know this has been a hot topic, especially after this latest bronchiolitis season, because it was very hard to manage the influx of patients, and everyone, I feel like, wanted something to be standardized. So there wasn't a standard protocol for initiation, escalation, or weaning high-flow nasal cannula in their PICU. They developed an RT-driven high-flow nasal cannula management protocol, and it was still for those children under 2 years of age who had that diagnosis of bronchiolitis and were in the PICU. So they had an objective respiratory score that was implemented in 2017, and then their goal was to decrease the duration of high-flow nasal cannula usage. Hopefully you can see this. I know it's a little bit small, but this is kind of what their key drivers looked like. So when they initiated this protocol, they really wanted to make sure that, number one, it was going to increase staff engagement because it's not going to work if the staff don't do it. Number two, they wanted to standardize the respiratory status assessment and the documentation that goes with it, because you need to assure that the data that you're collecting is good. And they wanted to standardize the high-flow nasal cannula management and that documentation. So you can kind of take a look at that. We can hopefully provide that as a reference for you afterwards too, if you would like to look at that further after this presentation. So they used some interventions such as scoring tools, the protocol itself. They did regular audits, and then they provided education to RTs, nurses, and MDs. So their outcome measure was their high-flow nasal cannula duration per patient. Their process measure was their protocol compliance, and then their balancing measure was if they were on NIV, what the intubation rates were, and 30-day PICU readmission rates. Here is kind of the scoring tool that they used. Again, I know that's a little bit small to read, but basically it was a scoring tool based on the age of your child, or the category that your child fits in. So newborn, infant, toddler, school age, and adolescent. And then meeting certain criteria puts you in that category. And then basically you score your patient based on their respiratory work of breathing. And then here is the algorithm that they used for their high flow protocol, and their age really determined the set flow rate, and then their score is what determined their weaning or escalation. So they knew what place they had to start at based off their patient's age, and then they knew where they needed to go based off the respiratory scoring tool that I just previously showed. So an RT-driven high flow nasal cannula management protocol is pretty awesome that this even happened. It showed that there was protocol compliance. It actually was sustained and above 80% of their goal for 4 months of implementation. Their high flow nasal cannula duration actually decreased from 2.5 days to 1.8 days after implementation. Their PICU length of stay decreased from 2.6 days to 2.1 days after implementation, and their hospital length of stay decreased from 5.7 days to 4.7 days. So this, plus the PICU length of stay decrease, would decrease overall healthcare costs, which is a huge, awesome factor. And their NIV rates and intubation rates didn't show any significant change. So RTs also reported increased engagement, which is also a big deal. So this is an awesome study to go just kind of reference back at and kind of maybe bring to your teams and talk about if this would be a good fit for your environment. And as I hand it off to Dr. Shein, I just want to reiterate the fact that what we just went through, and some may still be going through, was just unseasonably early. However, what we are learning, and I know that there are some researchers out there looking at this, what we know from 2020 is that what our norms were aren't necessarily our norms now. So that environmental temperature that we thought, pretty confidently predicted our seasons of different viruses might not necessarily be as true as we once thought. So for us as clinicians, it is so important for us to continue to research and to continue to try to move forward with our best practices so we are adaptable in all of those situations. And with that, I will hand it off to Dr. Shein.
All right, well, thank you, Anne, for such a great initial presentation, and thank you to everyone at ARC for the invitation. So we only got about 15 minutes to leave time for Q&A, so let's get cracking. We are going to talk about systemic therapies, specifically corticosteroids and antibiotics, and then spend the majority of our time talking about positive pressure respiratory supports, specifically CPAP and basic mechanical ventilations. And Anne's already talked about more mild supports like high flow. As probably many of you are aware, there are multiple guidelines given by the AAP and other similar institutions and societies across the globe. Unfortunately, for management of the most severe cases, these aren't really helpful. There's unfortunately a paucity of data in critical bronchiolitis compared to the large number of studies that have been done in the ER setting and on the general ward setting. So most of these guidelines specifically say they don't apply to critical bronchiolitis, which sort of leaves me and my colleagues in the ICU, along with our RTs as well, to sort of use the evidence as best we have, as also along with our clinical experience. That doesn't stop us from using these medications. When you look at data from around the world, from the United States, from Spain, Australia, Latin America, and Israel, we use things like steroids and antibiotics very frequently in our children with critical bronchiolitis, despite a lack of evidence to support evidence-based practice guidelines like the AAP. A couple years ago, when my partner here at Rainbow, Catherine Slane, and I were asked to write the bronchiolitis chapter for the Furman Pediatric Clinical Care textbook, we did review all of the pertinent literature that was available at the time. In summary, for corticosteroids, they've been pretty clearly shown to be ineffective in more mild cases. And there are some data unique compared to things like bronchodilators and antibiotics, as we'll talk about shortly. There are some prospective randomized controlled data that can help us a little bit with corticosteroids. One of those trials was done in Belgium by Joe Van Wassel and his group. They enrolled about 80 children who were mechanically ventilated for RSV bronchiolitis and randomized them to Decadron versus placebo. And overall, they found no difference in duration in mechanical ventilation. But if you look at table 3, you do see that in what they call the bronchiolitis subgroup, which is a group with more mild hypoxemia and not needing a higher mean airway pressure, they found that steroids actually shortens duration in mechanical ventilation in these more mild children. So they did a follow-up study that was more intended to focus on, to test the hypothesis of kids with mild hypoxemia. And unfortunately, in that follow-up study, which was actually a little bit larger, they did not confirm that, showing that there was no consistent benefit of steroids in mechanically ventilated children with bronchiolitis. Subsequent studies done here in the United States, a two-center study done out of Memphis and Dallas, again found no benefit of steroids to shorten duration of mechanical ventilation. And one of the most interesting things about this American study is its main primary outcome was to actually look at viral clearance from the respiratory tract. And they found that steroids actually slowed down or worsened the ability of the child to clear RSV from the respiratory tract. So clearly there's a potential harm from giving steroids as well. What makes it particularly challenging, though, is those studies are both 10 to 20 years old. And there's a more recent study that came out in JPEDS not even a year ago. This was done in Australia, if I remember correctly. And they randomized children who are more typical kind of current critical bronchiolitis patients, so a large number of them on high flow and CPAP, to a combination of racemic epi, given serially, initially kind of like Q1 to 2 hours and then spaced out as time goes on, and Decadron versus placebo. So either got racemic epi and steroids or they got placebo. And what they found is with that treatment approach, they actually shortened the time that these children require these ICU level respiratory therapies. It basically got them off of high flow and above faster, got them out of the ICU faster. One of the things that I found most interesting about this study is that when they looked at subgroups, it was the kids that at least I would think would be less likely to benefit. It was the kids without chronic lung disease, and it was the kids with RSV, so not rhinovirus, that actually had the benefit from the steroids and racemic epi. Now, myself and Nader Yeha from CHOP were asked to write the editorial about this because we're the reviewers for the article. There were some methodologic concerns that we raised with this, specifically the fact that unlike some of the studies that Anne was talking about before, they didn't have a explicit weaning protocol. And so I think that does lead to some concern about sort of taking this as gospel. And so while these data are fairly convincing and are similar to a single study that came out of the Canadian ER trial group a number of years ago, where they similarly found a signal that suggests a benefit of combined therapy with epinephrine and Decadron combined. I don't think these data are relative or right. So in summary of this slide, because I'm not sure exactly where it's cut off, this more recent study from the ICUs in New Zealand or Australia and the more historical study at the Canadian trials group, I think it's interesting, but I don't think it should make us feel that a combined therapy with racemic epi and Decadron is a standard of care. And in part because the prior data shows that there's potential harm from steroids. So it's pretty clear to me, at least, that steroids don't benefit all patients and might cause some harm. But I think, I know for myself, and I imagine many of you guys have seen kids at the bedside that do seem like they have a very tremendous response to a dose of steroids, that you give them that and suddenly a couple hours later they're a whole new child. The problem is that we don't have a way to identify those kids at the bedside. And the data don't show that it's sort of like the kids that you might expect, the kids with chronic lung disease that are more like the rhinovirus kind of baby asthma phenotype. So, sorry, I clicked the wrong button there. So my general approach is I rarely use steroids on non-intubated kids. And if I'm using on intubated children, it's usually because I've seen very clear objective data for reversible bronchospasm on the ventilator, or I'm using it to prevent upper airway obstruction peri-extubation. Now, I mentioned before that the AAP guidelines and the NICE guidelines and all those, it's basically exclude children with critical bronchiolitis from their recommendations. And until very recently, there were no kind of large expert and evidence-based guidelines for critical bronchiolitis. But literally just in the last couple of weeks, Christophe Malessi and a lot of the French intensivists that do bronchiolitis research published in intensive care medicine their clinical practice guidelines for managing children with critical bronchiolitis. And they basically have the same conclusion that I do, that corticosteroids, neither inhaled nor systemic, should be used routinely in these children. Now, moving on quickly to antibiotics, and then we'll get into CPAP and invasive. Fairly well done studies show that in intubated bronchiolitics, somewhere around a quarter to a third of them historically have evidence for concurrent bacterial pneumonia. Myself and some partners both here at Rainbow and also at UAB and Boston Children's did a study that was published in Peds Critical Care Medicine a couple of years ago. This is a database study using the FIZ database, which is data from about 40 or so children's hospitals across the United States. And we looked at kids who were mechanically ventilated for RSV bronchiolitis, who either received antibiotics on both of the first days of invasive ventilation or on neither. So essentially treated with antibiotics or not treated with antibiotics. We looked at more than 2,000 children, found that over 80% of them were treated with antibiotics, showing how frequently us intensivists do this. And interestingly found that the kids with that were treated with early antibiotics, seen in the middle column here, had a shortened duration of mechanical ventilation compared to the kids that did not get early antibiotics, which is pretty surprising for a disease that is predominantly caused by viruses. When we adjusted for illness severity and for demographics as best we could, we found that there still was a statistically significant association between early antibiotic use and shortened duration of ventilation and shorter ICU length of stay. What I found potentially most interesting of this whole study is we then looked at the kids that did not have a diagnosis code for bacterial pneumonia. So these were the RSV bronchiolitics who were intubated, who the clinician didn't diagnose with pneumonia. And even in that subgroup, antibiotics were still associated with improved outcomes, with getting off the ventilator faster, getting out of the ICU faster. Now, I don't think this means that every child with RSV bronchiolitis benefits from antibiotics, but I do think it shows that we certainly don't know how to reliably and accurately diagnose bacterial co-infection in these kids. So the French guidelines say that you should only use antibiotics when you suspect pulmonary superinfection or bacterial co-infection. I would argue that that's basically impossible to do at the bedside in a reliable manner. And that antibiotics should, theoretically, benefit kids with bacterial co-infection with little effect on the kids that don't have it. So my personal approach is that I give antibiotics to pretty much every child with clinical bronchiolitis that we intubate. We get an endotracheal tube culture soon after intubation. We give them basically 48 hours, and if their culture grows, strep pneumo or whatever, we treat it, and if the culture comes out negative, we stop it. And I almost never use antibiotics on my non-intubated patients. So let's move into positive pressure-based respiratory therapies. So we know from some elegant studies done by groups around the world that CPAP can have marked improvements in children's work of breathing and on their ventilation. And these are all studies of children with bronchiolitis. In this particular study, it was a crossover study, so half the kids just got standard oxygen therapy first, half the kids got CPAP first, and you can see that their PCO2 is plotted on the y-axis. And for the kids that got nasal cannula first, from between the start and 12 hours later, there were very little change in their CO2 levels, while the kids who were put on CPAP had, in general, decreases in their CO2 and improved ventilation. Now, people often debate kind of high flow versus CPAP for these children. And one of the landmark studies in Peds Critical Care overall that was published in 2022 was the first ABC trial that came out of the United Kingdom. This was a large study of general pediatric critical care patients who were thought by the clinician to need either CPAP or high flow. Not surprisingly, bronchiolitis was the most common diagnosis, so half of this entire study was children with bronchiolitis. And they found that when randomized to either high flow or CPAP, there was no difference in time to liberation off of ICU level respiratory support, to the point that high flow was deemed non-inferior to CPAP. When they specifically looked at children with bronchiolitis, again, you can see there's no statistically significant difference between starting with high flow and starting with CPAP. There have been a multitude of smaller studies that were published before First ABC. This is from a commentary that I published along with Martin Neiber and Alex Rhoda in Peds Critical Care in response to the First ABC trial. And I highlighted the bronchiolitis studies that all show basically no difference in outcomes between starting with CPAP versus starting with high flow. The one outlier was Christophe Malessi's Tramontane study. He's the first author of the French guidelines I talked about. This was published probably 8-9 years ago now, where they randomized about 150 children with bronchiolitis to 2 per kilo of high flow versus 7 centimeters of CPAP. And here they actually did find a difference in the episodes of treatment failure, with high flow being worse. And you can see in the figure that 50% of the high flow kids failed versus 31% of the CPAP kids. And so you would think then that this could be suggestive that high flow actually might be inferior, that CPAP might be better, even though all those other studies would argue that they're the same. But I find most interesting is that in their follow-up study, the same group did the Tramontane 2 study. And in this one, it was just high flow, 2 per kilo versus 3 per kilo. What's interesting, though, and I think very important if you're trying to look at the Trauma Untamed 1 study, is that these French intensivists, now that they had more experience with high flow, they found that the rate of failure, in bronchiolitis patients, was down to 38% now that they had some experience, markedly lower than the 51%. So we actually wrote a letter to the editor about this, and Melessi et al. In their reply agreed that because in the Trauma Untamed 2 study, the same intensivists taking care of the same patients now had a much lower failure rate, and because failure of high flow and failure of CPAP really is such a subjective thing that it calls into the question the results of Trauma Untamed 1. Now, this didn't stop the French recommendations from suggesting that CPAP should be the first-line therapy over high flow for more severe cases, but I'll tell you, I almost never practice like that. I almost always use high flow before CPAP, and we have a very high success rate at our institution with that, as I know many across the country and across the world do. For myself, if I have a child that's failing high flow, I'll usually try CPAP before moving just to intubation, starting somewhere in the 5 to 7 meters of water kind of range, usually maxing out around 8 or 9. And if a child's failing CPAP, sometimes I'll try BiPAP, or sometimes I'll just move to intubation, depending on sort of how severe the kid is. So let's close with talking about intubation. So I'll tell you, I really try to avoid this unless it's absolutely necessary in children with bronchiolitis, because frankly, they are a giant pain when they're on the ventilator. But sometimes it's necessary, particularly for refractory hypoxemia, if the kid's needing more than 60% on high flow or CPAP. If they're having clinical evidence of hypercarbia, such as being obtunded, and personally, I very rarely use blood gases with kids on non-invasive or high flow. If they have severe work of breathing, and especially if there's systemic signs of stress. So if they're really tachycardic, if they're getting lethargic, their respiratory rate in and of itself, like to me, it doesn't really matter if they're breathing 80s and 90s, as long as they're alert and not tachycardic, they're tolerating it fine. And then there is, as Anne mentioned before, sort of that phenotype of those recurrent apneas, which sometimes, especially if they're associated with bradycardias and desaturations, you have to put a tube in for a couple of days till they get over it. My personal approach to intubation for kind of induction medications is to use fentanyl, Versed if they're not in shock, and rocuronium. Certainly just try to pre-oxygenate them as best as possible. Definitely have suction ready, have fluids and atropine ready in case of any kind of cardiovascular issues. And always, always, always put a cuff and a tracheal tube in. And that really goes, in my opinion, for basically any child they're intubating for any reason, but especially if they're going to have lung disease and potentially need high peak inspiratory pressures. Usually trying for a 4.0 tube, sometimes a 3.5 with a small baby, and obviously having smaller sizes ready to go as well in case they're always a little tight. Once they're intubated, there's no obvious and definitive way and singular way to ventilate all children with bronchiolitis. And that's because we've known for decades now that these children can have very different kind of respiratory parameters and can have very severe obstructive disease and very severe restrictive disease, and sometimes, frankly, a little bit of both and kind of vacillating between the two. So you can't just use sort of like an asthma approach. You can't just use an ARDS approach. You have to kind of titrate it and tailor it to that individual child in that individual moment. So personally, I almost always use pressure-regulated volume control, or whatever brand of ventilator you use calls that. Starting with a rate somewhere in the mid to high 20s, 8 per kilo of tidal volume, a peak of 7 to 8, maybe even a little bit higher if they're particularly desaturated, and an FiO2 of 50 or 60% to start. And then I just adjust everything for what I think are reasonable goals, aiming for a little bit of permissive hypercapnia, 725, 730 kind of range, making sure we try to keep their stats in the mid-90s, but certainly not needing to aim for 99 or 100. And then if they are more hypercarb than they want them to be, sometimes they're going to act very obstructive, and you have to lower the rate because they're not fully exhaling, or looking at their loops, you can see that there's an obstructive pattern. And those are the kids I'll often trial bronchodilators on, and potentially steroids if I see a good effect. If, on the other hand, they're acting more restrictive and they're fully exhaling but still hypercarbic, increasing the rate, and sometimes increasing the tidal volume too, as long as their pit or their plateau pressure is adequately low. And sometimes, frankly, you have to tolerate fairly high pips, I find, in these kids for a period of time until they sort of kind of get their act together. Obviously, if you need to improve their oxygenation, besides just titrating their FiO2, you can try to find the right peak for them, making sure that you're not over-distending them, and also sort of making sure that you're not under-recruiting them and giving them the adequate peak that they need, which sometimes is in the 10, 12, 15 kind of range. And that is the end of my slides, and we still have 10 minutes left. Apologies again for the technical issues before there, and thank you again for the invitation to speak today.
Wow, thank you Thank you so much, Dr. Shein and Annie. That was a lot of incredible information. Right now, when I'm going, if you guys have questions, I am going, if you want to type them into the Q&A box here, and we have a few minutes here that we can start going through these and answering your questions. And there's one question here from David Lockwood asking, there have been 2 studies using IPV, one from Belgium giving 1 treatment per day and one from Israel giving 2 treatments per day, showing 1.5 to 2 reduction in hospital length of stay. Can you speak to these studies? Dr. Shein or Annie, I'm not sure if either of you have utilized that or sorry, are aware of those studies or have any experience to share for this.
So I don't know the studies off the top of my head, so I can't speak specifically to their methods or results. I can tell you that we use IPVs with a modest frequency in our ICU, no pun intended. I've seen some kids that have a very positive response to them. They get tons of secretions out and suddenly their lung mechanics are a lot better. I've also seen some kids that frankly get really destabilized by them too, either because they find it to be noxious or because it causes enough kind of shifting and mucus plugging that it probably worsens their VQ matching hypoxemia. So I don't think they're unreasonable things to try as long as you have the equipment and expertise in how to use it. But I don't think they're a panacea. And I, again, can't specifically speak about the studies themselves.
Yeah, because this question came on earlier, I was trying to see if I could find that study specifically. I could not, so I can't speak to the study either. I have worked at institutions that utilize the VDR for many of our critical bronchiolitis patients. Not a lot of data to support it, but we did have a lot of good anecdotal, which if you're not familiar with the VDR, it is essentially a form of high-frequency percussive ventilation. It offers a lung protective strategy with a continuous percussive of the IPV of the IPV throughout all of the cycles. So for our patients who were in ARDS and needed enhanced secretion removal, again, there's not a lot of data, but anecdotally, I can tell you that it worked really well in being able to provide safe, protect their lungs and enhance their secretion removal. So I can't speak to that study, but I can tell you that in a small subject of patients, I'm not really able to define clearly. It did work. This form did kind of help work for us and our patients.
Yes, and I don't have any familiarity with that study either, so I don't really have anything to contribute to that question.
Oh, thank you. Another question came through on thoughts of vapotherm treatments. I'm not certain what the question is specific to. I'm going to guess it means using vapotherm specifically as a high flow, or it may mean even giving treatments via vapotherm or high flow. I'm not certain, but I'm not sure if you guys have any thoughts on that.
We don't specifically use that device at our facility, so and every facility is a little bit different, so kind of using what works for you is kind of what's most important, but I don't have any specifics towards that particular device.
Yeah, and we use both vapotherms and the Fisher-Paykel Airvos. Frankly, the only reason I have any preference towards the vapotherm is just because the display is so easy to read, so it's very easy to walk by a patient's room and see exactly how much support that they're on. But as far as I can tell, I don't see any real clinical benefit of one particular brand of high flow versus another.
Perfect, thank you. Another question is, do you use NAVA at your facility? And they are likely asking, have we been using NAVA in these patients?
We have not.
So we do on occasion, but I know there are some centers, because I have colleagues that work at them, that swear by this, both for non-invasive and for invasive support for bronchiolitics. We just haven't gotten into the habit of using it, and so we tend to reach for it sort of for kind of last-ditchy kind of things, which is generally not a great way to establish a good comfort level in practice. But it certainly is at least to me, a very intriguing and kind of logical thing that could benefit, especially for hopefully trying to stave off intubation if you use it non-invasively, or to help these kids sync with a ventilator faster, maybe help prevent them from needing to be deeply sedated and muscle relaxed if they are invasively ventilated.
Thank you. And another question, with regard to superficial versus deep suctioning, how would the group approach hesitation with practitioners, including nurses, RTs, and MDs, with deep suctioning, knowing there is not a lot of data to support its use?
I think it kind of goes back to education for everybody, nurses, RTs, and clinicians and the physicians as well, and really kind of all being on the same page about optimizing everything about that patient first, right? You may not get a ton of secretions out by just nasally suctioning, but is your hydration optimized? And if not, then you're probably not going to get much out deep suctioning either. But I know deep suctioning makes us feel better because we feel like we did everything we could. But it's also just kind of presenting the data and kind of talking about that with your teams, maybe in just some sort of kind of informal roundtable learning discussion about what data is out there and what does work or what doesn't work. And then maybe you could even pilot your own little mini study at your facility and kind of compare and contrast and see what kind of data you get.
Yeah, and I think it's also just about trying to kind of tailor the risk benefit for that individual child, right? Because like the benefit of deep suctioning is you might get some obstructive secretions out and improve the child's lung mechanics. The downside, though, is you might cause trauma and then replace whatever you did get out with more swelling and even bleeding too. And so I think you have to sort of tailor to that kid about how much they'll tolerate and how much benefit they're getting versus the risk of doing it too frequently.
Perfect, thank you. And have you seen a higher percentage of patients responding to bronchodilators this viral season? This individual says they have. I have heard a few whisperings of that, of some that they believe that this strand might have been more responsive to bronchodilators. I've not seen that or read any data on that, but do either of you have any information about that?
So yes, a little bit actually. So there is a study out there that kind of looked at I'm going to forget the word, but basically what they did is they tried to take a look at the genetics of some of those patients to see if they were more prone to being responsive to albuterol. And so it was taking into consideration that aspect of it. And so what it talked about was basically that, some of the time maybe those patients were responsive because they had that part of their genetic makeup. I'm trying to find that study for you real quick. Dr. Shein, do you have anything to chime in with while I look for that?
Yeah, happy to share my thoughts. I'll preface them saying that they're a bit nihilistic. So I definitely think I'm seeing more kids being treated with bronchodilators this respiratory season. Whether they respond, I don't think we actually know. And so I say that based on a fairly well done study that came out of Connecticut Children's by a guy named Chris Carroll about 10 years ago or so. And in this study, he took kids who were intubated with RSV. So obviously you could measure airways resistance through the ventilator, who the clinical team was going to give an albuterol to. And the really cool novel thing that he and his group did is they had the physician, the nurse, and the RT listen to the child before and after, which I think is how many of us say a kid responds, and say whether or not they thought clinically the kid was a responder, while behind the scenes he was actually measuring airways resistance and objectively saying who a responder was. And so at the end of the study, they had, X percentage of kids, I think it was like 30 or 40%, that were responders. And they were able to see basically how good us physicians and all the RTs and all of the nurses are at being able to actually objectively figure out who's a responder and who's not. And it showed that we're as good as a coin flip. Like really, it was like almost exactly 50-50. And so I think that we just have a lot of issues, not for lack of effort and not for lack of experience or expertise, with actually identifying kids who have reversible bronchospasm just by auscultation and clinical exam. So I do think there are lots of kids being treated with them. I don't think we have a way to actually say that they are true responders in any reliable way, though.
That's really neat. Yeah, the study I was referring to was also, to tag on to that, was talking about the different phenotypes and endotypes that may be helping comprise bronchiolitis in general. So there might be a degree to which bronchodilator therapy might be beneficial for some of those patients. That was a good question. That was fun.
So totally agree. Like there are kids who definitely act like little baby asthmatics. You give them albuterol and steroids and they get better, or you give them racemic, which is my personal drug of choice, because then you get a little bit of vasoconstriction and some improved airway edema too, and they get better. The thing is, I just don't think we have a reliable way to identify those kids at the bedside, and it leads to a lot of overtreatments because we just don't have that system yet.
All right. Yes, thank you. A lot of great questions. I apologize, we are out of time. So I want to thank both Dr. Shein and Annie again for taking the time to speak with us today. And to all of you, thank you so much for joining. Please join us for our next broadcast on January 20th for the January 2023 Journal Cast, which will be presented by Chandler Jones and moderated by Cheryl Skinner. Thank you again, and I hope you all have a wonderful day.
Thanks, everyone. We would like to thank our speakers for sharing their excellent presentation, and thank you also for our participants for joining us today. If you're a group participant, please have your group leader submit your information to the group attendance tab to be provided with follow-up instructions on how to submit for credit. If you have any questions, please email crce@aarc.org. This concludes today's presentation. Once marked concluded, the system will automatically submit credit for you after you complete the survey. You can check your status in the credit submission tab. We hope you all have a great afternoon.